We're here today to do our second part of our deep dive into Breast Implant Associated-ALCL. Our guest this afternoon is Dr. Marshall Kadin. He is a clinical and research pathologist at Boston University and at the Rhode Island Hospital, and his laboratories are at the Roger Williams Medical Center in Providence, Rhode Island. He is a world-renowned T-cell lymphoma expert. So we have a couple of questions for you today. The first question that I wanted to ask you was if you can elucidate for us, in what ways would you say that breast implant associated ALCL is similar or different from the cutaneous and systemic T-cell lymphomas that you've studied for all these years?
Well, that's obviously a complicated question, but the main similarities are the morphology or the pathology of all of these lesions, which feature a particular type of large cell with a bizarre nucleus that's referred to as an anaplastic cell. They are, all of these disorders, the tumor cells are CD30 or Ki1 positive, and express variable numbers of T-cell antigens. But the expression of these antigens is abnormal compared to a normal T-cell. The childhood type of anaplastic large cell lymphoma is distinguished by the expression of an anaplastic large cell lymphoma kinase called ALK, which is absent in the breast implant and cutaneous anaplastic large cell lymphomas. So that's a major difference. Clinically, the breast implant ALCL, I think, resembles cutaneous ALCL in that it is the end stage of a spectrum of a lymphoproliferative disorder, which begins with a initial self-healing phase that, despite its clinically benign behavior, has a very malignant histopathology. So there's, from the beginning, there was a lot of confusion about why the cutaneous early lesions regressed spontaneously. So because of the many similarities to the breast implant ALCL in terms of the pathology and the immunophenotype, I feel that it's likely that the breast implant ALCL is preceded by a similar clinically indolent phase, which we have yet to identify and is kind of the holy grail for what we want to do.
In other words, to put this into terms that a lot of the listeners could understand, there are different stages at which this could be found. And the question is, are those different stages always malignant? So can you have seroma disease that is not truly defined as malignant, and when does it become classified and go from what you're calling a lymphoproliferative stage to actually being diagnosed as a lymphoma? Is that what you're trying to get at, that that's what we're looking for?
Well, the issue here is what do you call malignant? So this malignant is defined more as an aggressive disease. And we know that in the cutaneous analog, even though there's an earlier stage where the cells have a malignant appearance, they behave, or the lesions behave in a benign fashion. So we would like to identify a similar early stage in the development of breast implant ALCL. Now in the skin, it's more, it's easier to identify that early stage because you can visually see the skin lesions and watch their behavior and their spontaneous regression. We don't have that advantage in studying breast implant ALCL. But curiously, the natural history of the two disorders seems to be similar. By that, I mean that in my experience, following patients with the cutaneous disorder, it takes an average of around 10 years to progress from the early pre-malignant or indolent phase to developing a full-blown ALCL, which has a potential to metastasize. And from what we understand about the history of the breast implant ALCL, it follows a similar delayed course of, say, 7 to 10 years to develop. So that's another interesting parallel.
So the cutaneous can go on to a systemic ALCL?
Yes. Usually it first develops a local, one or more local tumor masses that remain localized to the skin. And then similar to the breast implant ALCL, the next step is usually spread to regional lymph nodes. And only rarely do you then get dissemination to viscera, which can cause, fatal outcome.
That's really interesting.
Yeah.
So you've received a grant from the Aesthetic Society Research Foundation. What do you plan to do with your research with that grant?
Well, I'm very grateful to have received that grant. And my focus there is to try and identify or more fully characterize the early precursors of BIA-ALCL. And so my approach to that is to better understand all the characteristics of the anaplastic cells in the full-blown breast implant associated ALCL, and then look back at these featers in clinically benign seromas to see if I can detect some of the similar biomarkers. Now we reported one series of biomarkers in the Aesthetic Surgical Journal a couple of years ago. So for example, one is called JUNB, which is called a proto-oncogene, which means it's not a fully developed oncogene, but it kind of programs cells to grow more quickly. And so you can see that expressed in all of BIA-ALCLs. And to some degree, we see a few cells in the benign seromas stained for JUNB. So that's just one example of the various markers that we're looking for. There's also the abnormal pattern of T-cell surface antigens that I mentioned that we can look for. And one of the approaches we can use are to sort cells. And we know that CD30, although it's characteristic of the malignant disorder, it may also be found in an early pre-malignant disorder in a case that I published with Dr. Glicksman. Another approach that I have is that I found that the full-blown anaplastic cells secrete a cytokine called interleukin-13. And that's very, I think it's very interesting because it tells us a lot about the disease. Interleukin-13 stimulates plasma cells to make immunoglobulin E, which is normally present in very trace amounts in normal individuals. Now, interestingly, when I look at biopsies of breast implant ALCL, I find IgE bound to the surface of mast cells, which have not previously been described in breast implant ALCL. And it's known that when IgE binds to the surface of a mast cell, it activates it to produce various chemokines. And one of those chemokines is prostaglandin D2. And interestingly, prostaglandin D2 attracts eosinophils and certain classes of T lymphocytes. And we find, amazingly, we find receptors for prostaglandin D2 on the anaplastic cells.
Yeah.
So the last point I wanted to mention is that in addition to prostaglandin D2, the activated mast cells also secrete histamine, and histamine makes blood vessels leaky. And so I want to explore the possibility that histamine from these mast cells may contribute to the formation of the seromas.
Question that pertains to genetics. We've had multiple theories of what initiates the entire process, going from a bacterial antigen load that's presented to the host, all the way to different theories about different implant surfaces, etc. What role does the specific genetics of a patient play in this? Because we're seeing it, it's a combination of multiple factors, but in what way do you feel that the genetics of a particular patient plays a role?
Well, first of all, we've learned that breast implant ALCL is very rare, or maybe does not occur at all in women of Asian ancestry. This is despite the fact that in general, T-cell lymphomas are more common among Asians than they are among Western people in Western countries. So that's kind of a curious issue. The other thing is that the anaplastic cells have HLA determinants on their surface, and for a long time it's been suspected that there may be some link between HLA phenotypes and the susceptibility to develop breast implant ALCL.
All right, so that we've completed a very interesting discussion on breast implant associated ALCL. In our first discussion, we talked to Doctors Anand Deva, Mark Clemens, and Steve Teitelbaum. And Anand talked to us about the 4 factors he sees as the likely etiology, including a textured surface implant, exposure to bacteria, a genetic predisposition, and time leading on to this. Mark Clemens talked about how patients usually present with swelling of the breast with or without a mass, diagnosed with by ultrasound and fluid, which is aspirated and sent for CD30 testing, and how many of these patients can be cured if caught early with just surgical intervention. Then Steve Teitelbaum talked about how he approaches patients when they come in for a consultation and considering implants, what he tells them about ALCL, that this is rare, but it does happen. It's something to be aware of, especially in patients considering textured surface implants. So we've discussed with patients advantage and disadvantage of each with the risk factors and help them make a decision on what's best for them and what risks they're willing to take. Joining us now is Dr. Bill Adams, who's an associate clinical professor of plastic surgery and a director of the Aesthetic Fellowship at UT Southwestern in Dallas. Dr. Adams has published numerous articles on breast implant associated anaplastic large cell lymphoma and has educated surgeons and patients from around the world on this topic. For our final segment, we will do a joint session with Dr. Adams and Dr. Marshall Kadin to wrap up our deep dive.
Well, first, Pat and Caroline, I'd just like to congratulate both of you for, I've been following last week's discussion and this one, and you both have done a fantastic job of leading and facilitating discussion around this, difficult and interesting topic. So congratulations to that. And I would tell you that I've learned a lot about this disease in the past 5 to 6 years. The notion that, that was the initial notion that it was caused by an implant, a certain type of implant, which was a BIA-ALCL textured implant. I think that theory has really fell by the wayside, although there are still some people promoting it. But if you look at what we know and what we see in terms of where the cases are, the distribution of those cases, or the case clusters, for example, if there's one individual or center that has 7 or 8 cases, it just doesn't fit that an implant is causing that. You just wouldn't see the distribution of cases. Logic would just prove that to yourself. So it's very similar to, I think, and obviously, this concept of the microbiome causing issues, we know has caused capsular contracture, which is the most common risk for breast implants. But the microbiome is very important now, as we understand more, in the formation of many diseases. So this idea that colonization and chronic inflammation by bacteria or certain types of bacteria can trigger this process, I think is one that has a lot of weight and is the one, it's really the only one that we know that fits what we see and have observed already with these cases. And then you take on top of that, you know, we've got the world's authority here with us today, Dr. Marshall Kadin. Marshall described, he was the first person to ever describe cutaneous lymphoma. So he knows probably more about that than anybody in the world. And so Marshall became interested in breast implant ALCL because it's very similar pathways that he was seeing. And so now obviously we've commissioned him through ASERF, the Aesthetic Society Education and Research Foundation, to do a lot of research, and he's already shown that breast implant ALCL is very closely related to cutaneous ALCL. So I think that it just doesn't make a lot of sense that this is just coming from an implant. It would be the same thing when you have a skin cancer, say that you say, well, it's just the skin is bad. It's not the skin is bad. The skin is exposed to the sun, and the sun transforms the skin into having a problem, but the skin wasn't originally bad. The same thing. The implant is just a carrier, just that what we've learned is that it's probably the implant harbors bacteria. The textured implants harbor much more bacteria around there, and you have much more chronic inflammation. And I think that really is the pervasive theory that we're working with at this point.
So the patients with the stage 1A, the seroma only, are those patients, is that considered malignancy, a CD30 positive, ALK negative? That was a discussion we had last time, whether that could be considered an in situ cancer, the 1As, or is that a true malignancy?
Well, that's sort of a man-made definition or woman-made definition. You know, I mean, you know, how you want to call it. See, in the pre-malignant phase of the cutaneous ALCL, curiously, we find that most of the properties, if not all the properties of the cells in the self-healing lesions carry characteristics of malignancy. But somehow there's a self-limited growth. To try and identify the parallel cells in the breast implant scenario, we have to study clinically benign seromas to identify those progenitor cells, if you will.
The fact that it seems to parallel what Marshall described, cutaneous ALCL, is quite interesting, because cutaneous ALCL is a lymphoproliferative disorder. That's not to belittle this disease, to say that it can't have, you know, it's really not that big a deal. That's not the case at all. Lymphoproliferative just means there's a spectrum of disease. So at one end of the spectrum, you can have a benign, say a benign seroma that's non-malignant, it may be CD30 positive, or even most of us think that there's a progression. If you leave a seroma in the breast that's totally benign, over time, because of the chronic inflammation, it can go on to form a lymphoma, and if left for long enough, it can become a malignant and aggressive lymphoma. So lymphoproliferative, I think, is a spectrum of disease, and so it, I think, fits. Many of the patients we see fit into that, somewhere along that spectrum. The other end of the spectrum can be a fully malignant metastatic disease. The problem is if you classified it as an anaplastic large cell lymphoma, you have the vast majority of women that are being told that they have a ALCL, anaplastic large cell lymphoma, when they have something that behaves much more indolent than that. So it's unfair to the vast majority of patients. I think it's more fair for the patients to have a classification along the spectrum, where all of them can fit in. So to my way of thinking of it, I think it's just in a more advanced way of classifying this disease as we've known more about it. And Marshall, I don't know, what do you think about that description?
Well, during this discussion, it just occurred to me of another publication that I participated in with the National Cancer Institute. And this is a paper that was published in the last year with the senior author Thomas Waldman, who's head of the lymphoid malignancy branch of the National Cancer Institute in the NIH. He used for his study cell lines from cutaneous ALCL that I developed and some cell lines developed from breast implant ALCL by Alan Epstein at USC, and compared these cell lines, and they behave very similar. But the main point I want to make here is that even with mutations involving the JAK-STAT pathway, which is a common pathway in the development of hematopoietic tumors, these tumor cells do not have a malignant phenotype without external signals to their cytokine receptors. So that means that the external milieu, particularly cytokines acting on the cells, are required to confer a malignant behavior. So that's still another complication of this, but it also points out the difficulty in saying that a cell is malignant or benign, because the cell itself requires additional signals, even if it has mutations already in it.
And I think, Pat and Caroline, the one thing that it's not really the scope or the focus of any of these discussions, but just because there seems to be the concept that you have a textured implant, you have chronic inflammation by probably certain types of bacteria, you've got some genetic disposition and time, that you can't modify. We have no ability to modify or prophylax or reduce risk for most of those. So there's only two of those that we can really do anything about. That's the choice of implant, and then it's bacteria. And so, for plastic surgeons, and you all have been educating for a long time, one of the things we've done is we've really reduced the capsular contracture rate just through surgical technique, because capsular contracture is mediated by bacteria and chronic infection as well. So I think that's an important caveat of some of this discussion, that we have surgical techniques that can minimize risk. And, we actually published a paper that you all know of 42,000 macro textured implants, which we didn't have any cases of breast implant ALCL. Not to say that at some point somebody couldn't develop it. That really wasn't the point of the paper. But the point is that when everybody was using a certain type of technique, at least the rate right now, which is a mean of 11 or 12 years follow-up, was very low compared to what you would expect if it's 1 in 3,000 or 7,000 like the recent studies may suggest.
So what do you tell patients who have a textured surface implant, Bill?
So if patients have a textured surface implant, they just need to be vigilant and know if they have any change, which is usually a swelling of the breast, could be unilateral, could be bilateral, or any other change. They should come in and see their plastic surgeon. And the evaluation for that is, I think, fairly straightforward. So patients just need to be vigilant. But what they don't need to do is get hysterical. They need to replace their implants or have surgery, because if they're having no problems, we're talking about something and learning about it and trying to educate people, but this is still very rare. Even though the incidence is more now based on some of the studies than the original incidences we were quoting 5 years ago, 1 in 3,000 or 1 in 7,000 is still very rare. And it's also very treatable. Again, we published a study of a micromort of 0.34. That again lends itself to why Marshall is saying this probably behaves more like a lymphoproliferative disorder, because that means it's a very treatable condition if you diagnose it, and it's a rare occurrence that people will get this problem. So that's what we tell patients.
Well, I have a quick question for you. We talked a little bit about the steps that could be taken, and Nan spoke on this quite a bit about the steps that could be taken in the operating room to reduce contamination at the time of surgery. A lot of surgeons will take offense because they say, well, I'm not a sloppy surgeon, I'm a very neat surgeon, I follow these steps, but there are cases in patients where surgeons felt that they performed adequate prophylaxis of antibiotics. What do you think about the role of endogenous spread of bacteria over that's course of 10 years, 8 to 10 years, that should physicians also be thinking about advising their patients, like they do with total joints or with valves or whatever, to be on antibiotic prophylaxis for like the NON has and you have in the 14-point plan, anything that breaches the mucosa? Do you think there's a role of endogenous spread of bacteria that we should also be aware of just to reduce that potential? Yes,
so it's a very hard thing to prove, but I'm a firm believer of those type of prophylactic measures. So dental procedures is probably the most common one people undergo, because you do get a bacteremia when you have your teeth cleaned. And if you have a little capsular microfracture, you could reintroduce more bacteria around the implant at the time of one of those procedures. So I do think that's something that we practice in all of our patients, although that's certainly not universal at this point. The other important point is that just realize also that the other thing that's evolving through all this is bacteria. So 20 years ago, the bacteria that were in the world were far different than they are now. So they become more virulent. We've seen that in every other disease that there is. They become more resistant. And so, you know, what didn't cause a problem 10 years ago, now the bacteria could evolve and cause a problem. And the other point is that bacteria in different regions are even different. And so that's the factor, you know, it's bacteria, but you also have to consider what air we're talking about, you know, what air of bacteria, so to speak, and also where in the world it is, because the bacteria, even in St. Louis, where you are, or New Jersey, Carolina, or Marshall and Providence, are all very different than the bacteria in Dallas, Texas, and certainly across the world. So I think that's another factor that sometimes you know, people just don't realize that is important in this discussion.
Well, one thing that I found interesting but puzzling is that Ralstonia piquetii is one of the most prominent bacteria that Anand Diva identified in association with breast implant ALCL.
Yeah, that's exactly right. And I think, you know, as things have evolved, Ralstonia was initially implicated, and it still is. I think just the whole gram-negative spectrum of bacteria seems to be more important in this, based on further analysis of those specimens. So I think that, and that goes along with kind of what we've known for many years about capsular contracture. So the gram-positive bacteria tend to cause one host response in the body, which is a fibrotic host response, which we call capsular contracture. And if you have gram-negative predominance, you have a different host response, which turns out to be perhaps a transformative host response in the stimulation of T cells.
So I think we'll wrap up our first deep dive on a very important topic. We got a lot of information from true experts in the world. I want to thank Bill and Plastic Surgery Channel for organizing this, and all of our experts for joining us. And stay tuned for the next deep dive at some point in the future.